And for those of you who were not, what I plan to do is once a month, Respiratory Physiology 1, and we talked about ventilation. And today is Respiratory Physiology 2, which is a discussion of diffusion. So this was what we had spent last month talking about a fair amount, which was the relationship between arterial PCO2, CO2 production, and alveolar ventilation. Alveolar ventilation being the difference between minute ventilation and dead space ventilation. So this was the crux of what we had talked about last month. And I had said at that time that when I think about respiratory physiology, it is equations. So those of you who remember me from the NICU know that I like to work through equations. So as we talk about respiratory physiology, there will be some math involved. So this is kind of the overall scheme. So last time we talked about ventilation. Today we will talk about diffusion. Next month we'll talk about blood flow. And there are 8 different topics that are on the slide, which means that you may have to put up with me at least an hour a month for the next 6 months now. And then maybe we could start over at the beginning, or we'll find something else to talk about. So today we'll be talking about the physiology of diffusion. So we'll talk about Fick's law of diffusion. So that will be an equation again. We'll compare perfusion and diffusion limitations as they relate to gas uptake in the lungs. We'll describe how alveolar PO2 and exercise can affect diffusion, which explains why patients with COPD desaturate when they exercise, so more on that. Talk a little bit about causes of reduced DLCO. And then I thought this would be a good place to, since the first 4 objectives might only take a half hour or so, I thought this would be a good place to talk a little bit more about carbon monoxide. So we'll introduce that with a little discussion on the toxicity of CO, but then talk about some of the newer stuff, which is the biologic role of heme oxygenase. And then we'll talk about the potential therapeutic benefit of inhaled CO, and I'll share a little bit of the work that I have been involved with over the last several years in that regard. So this is the equation, Fick's law of diffusion. So Fick's law of diffusion says that the rate at which a gas will move across a membrane, in this case the membrane is the alveolar capillary membrane, so how fast the gas will move across this membrane will be determined by the area of the membrane, how big it is, how thick it is, the diffusibility of the gas, and the pressure difference or the concentration difference across that membrane. So if we break down these components then of Fick's law of diffusion, so first of all, talking about the area for diffusion in the lungs, normally the area for diffusion across the alveolar capillary membrane is about 100 square meters. So there's a big surface area for diffusion. So sometimes that's said to be about the size of a tennis court. If we took all of our alveoli and opened them up and laid them out side by side. So normally there's a big surface area for diffusion, but that is reduced by things like emphysema, where there's alveolar destruction, pneumonectomy, where part of the lung is taken out, pulmonary embolism, which effectively reduces the surface area for diffusion by reducing blood flow, and then things like pneumonia and ARDS reduce diffusing capacity. And in fact, with ARDS, the diffusing capacity is very low when it's been measured, and there's interest in measuring diffusing capacity in ARDS to evaluate the effect on recruitment maneuvers and so forth, as I'll talk about towards the end of the presentation. And then the surface area for diffusion is increased with exercise, because with exercise there is increased blood flow to parts of the lung that previously may not have been perfused as a result of the increase in pulmonary artery pressure that can occur with exercise. So the thickness of the alveolar capillary membrane is very small, 0.3 of a micron. So the lungs then are ideal for diffusion because there's a very large surface area, 100 square meters, and a very short diffusing path, a very thin alveolar capillary membrane. However, that the thickness of the alveolar capillary membrane can be increased with things like pulmonary fibrosis and things like pulmonary edema, which not only increase water within the lung itself, but also in the interstitial space, effectively increasing the thickness of the alveolar capillary membrane. The concentration difference is the partial pressure gradient across the alveolar capillary membrane, which is about 60 millimeters of mercury for oxygen. So in the alveolus, the PO2 is about 100. The PO2 in the mixed venous blood coming into the lungs is about 40. So there's a 60 millimeter of mercury concentration gradient for diffusion of oxygen. The gradient for diffusion of CO2 is about 5 millimeters of mercury. So the PCO2 in the alveolus is about 40. The PCO2 in the mixed venous blood is about 45. The diffusibility of the gas is a little bit more complicated, and it's based upon the solubility of the gas in the blood and the density or the molecular weight of the gas. And without working through all of the math, the bottom line is that the diffusibility of carbon dioxide is about 20 times, or on the slide it says 19 times, greater than that of oxygen. So because of the solubility of oxygen versus carbon dioxide, and because of the density of oxygen versus carbon dioxide, the rate of diffusion of carbon dioxide across the alveolar capillary membrane is about 20 times greater than that of oxygen. So this leads then to something that I think is a clinical myth that I've heard over and over in the clinical areas for now 45 years, which is that it's easier to clear carbon dioxide because of its greater diffusibility. So if we look at this, you would say, well, if the diffusibility of CO2 is 20 times greater than oxygen, it should be a lot easier to get CO2 out of the lungs than to get oxygen into the blood. And the reality is the CO2 clearance is much more dependent on alveolar ventilation than diffusion. So when we're thinking about clearing CO2 out of the lungs, this relationship is much more important than the Fick equation. And in fact, if there's no ventilation, then there's no CO2 difference across the alveolar capillary membrane, so diffusion is zero. So if we have no ventilation, then the PCO2 difference across the alveolar capillary membrane will be zero. So the diffusibility doesn't matter, because if this is zero, everything else becomes zero. So then I think it's a clinical myth when people say, well, it's easier to get rid of CO2 than to take up oxygen because of the high diffusibility of CO2. What clears CO2 is not diffusion. Diffusion has a minor part. Ventilation is much more important. So Fick's law of diffusion then says that the diffusion of a gas across the alveolar capillary membrane is directly proportional to area. And in our normal lungs, that's a large area. It's inversely proportional to thickness. In normal lungs, the thickness is very small. The area is reduced with things like emphysema, pneumonectomy, pulmonary embolism, ARDS, and the thickness is increased by things such as interstitial lung disease, pulmonary fibrosis, and interstitial edema. And diffusion is proportional to the partial pressure difference, but as I pointed out, even though the diffusibility of CO2 is much higher, clinically that often isn't very important. So what we're looking at on this slide is how quickly the concentration of a gas increases as the blood flows from the right side of the heart to the left side of the heart. So the alveolar PO2 is here. So for oxygen, that will be about 100. And as you can see, as the blood flows through the lungs, spends about 3/4 of a second in the pulmonary capillaries. Very quickly, if we look at nitrous oxide, N2O, very quickly the concentration of nitrous oxide in the blood increases up to what it is in the alveolar space. And you can see that normally for oxygen, that is similar to nitrous oxide. And in fact, normally for oxygen, after about a quarter of a second, the concentration, or the PO2, in the blood is the same as the PO2 in the alveolus. So then the only way that we can get more oxygen uptake from the lungs is to move more blood into the pulmonary capillary. So the way that we get more oxygen uptake into the lungs is that this blood has to move forward and bring more blood like this. So in that way, oxygen and nitrous oxide uptake is perfusion limited. So the amount of the gas which is taken up from the lungs is dependent upon how much blood flow there is through the lungs. Whereas on the other extreme, carbon monoxide is diffusion limited. And the reason for that is that the hemoglobin in the blood has a very high affinity for CO. So as soon as the CO moves into the bloodstream, it's bound up by hemoglobin. So the partial pressure of carbon monoxide does not go up very much in the bloodstream. So there remains a big concentration difference between the alveolus and the bloodstream for CO diffusion, so that in that way CO is diffusion limited. So that's why we use CO in the pulmonary function lab to measure diffusing capacity, because CO is diffusion, the uptake of CO is diffusion limited. Oxygen would not make any sense to be used because the uptake of oxygen from the lungs is normally not limited by diffusion, it's limited by blood flow. Now, if there is an abnormal diffusing capacity, such as with emphysema, alveolar destruction, or with pulmonary fibrosis, increased thickening of the alveolar capillary membrane, then the uptake of oxygen follows this path, where the uptake of oxygen may be diffusion limited with exercise, because with exercise the blood spends, instead of 3/4 of a second in the pulmonary capillary, may only spend 1/4 of a second because it's moving through much faster. So this then begins to give a clue to the fact that the patient with diffusion limitation, like the patient with COPD, with emphysema, when they exercise, the blood spends less time in the pulmonary capillary and their PO2 may indeed drop. So that is illustrated even further on this slide. So here is the normal situation for oxygen, where after about 1/4 of a second, there is equilibration between the PO2 in the alveolus and the PO2 in the bloodstream. And with exercise, we cannot reduce the amount of time that the blood spends in the pulmonary capillary to less than about 1/4 of a second. So in other words, for you or me, if we exercise, maybe for you, if you exercise more so than me, I should exercise more, but when you exercise, then you go from the situation here, where the PO2 in the pulmonary capillary is equal to the alveolar PO2, to here, so the blood's whipping through the lungs much faster, but in 1/4 of a second there's still time for the equilibration of the oxygen concentration in the blood and in the lungs. But if you have an abnormal diffusing capacity, such as a patient with COPD, emphysema, alveolar destruction, surface area of the lungs, instead of being 100 square meters, maybe it's 20 square meters. So now the patient with COPD, when they're at rest, they do not have diffusion limited uptake of oxygen. So their PO2 may not be so bad at rest. Maybe their PO2 is 70 at rest. But then when they exercise, what happens is they come to this part on the curve, because the blood doesn't spend as much time in the pulmonary capillary, and they desaturate. So this explains why patients with a low diffusing capacity desaturate with exercise, such as patients with COPD and patients with pulmonary fibrosis. Now here is the situation that occurs with a low alveolar PO2. So now let's imagine that your alveolar PO2, instead of being 100, as is shown here, is 50, as is shown here. So this is what would happen with altitude. So this is what happens in Denver, Colorado, mile above sea level, or Salt Lake City, mile above sea level, rather than in Boston. So again, at rest, so now there's only a 10 millimeter of mercury concentration difference for diffusion across the alveolar capillary membrane. So the mixed venous PO2 is still about 40, the alveolar PO2 is 50, so that now it takes more time for equilibration between the alveolar PO2 and the PO2 in the blood, so that that person in Denver, Colorado, or in Salt Lake City, at rest out here, may not have diffusion limitation. Their arterial and their alveolar PO2 will be very similar. But if they go up to Pikes Peak or try to hike, then with exercise, the blood spends less time in the pulmonary capillary. And in fact, normal people at altitude may have diffusion-limited uptake of oxygen with exercise. So not normally, but at exercise. Now, the patient who is really harmed by that is the patient with diffusion limitation. So the patient with COPD. So in a patient with COPD, because of the slower uptake of oxygen, because of the smaller concentration gradient, even at rest, they may have diffusion-limited uptake of oxygen, and it gets a lot worse if the individual exercises. So I can tell you that back, and Bob will remember this, back in the 1980s, some of the first studies were coming out about the benefit of oxygen for patients with COPD, particularly during exercise. And one of the criticisms of that work was the person who was doing the studies was Dr. Tom Petty. And where did he work? Denver, Colorado. So the question was whether the same thing would occur at sea level. So it turns out that based upon this, the same effect can occur at sea level, but it's a lot worse. Whoops, it's a lot worse if you are at altitude. This also will explain why patients with COPD may need oxygen during air travel, right? Because what's the pressure in the cabin of an airplane? It is pressurized to about 10,000 feet, I believe. Do you know, Bob? I think it's around 10,000 feet.
I don't know the precise.
The newer planes are 10,000.
About 10,000 feet.
Isn't that why a lot of people get sleepy on flights?
Pardon?
Do people get sleepy on flights for that reason?
Oh, I don't know. I get sleepy on flights. I think it's just because I'm bored.
Yeah, could be.
But this would also explain why someone in Boston with COPD, severe COPD, may need oxygen when they fly because the alveolar PO2 will be reduced, not to 50 millimeters of mercury, but it'll be to whatever the equivalent is of 10,000 feet. So then when we think about diffusion limitation as a cause for hypoxemia, it's unusual at rest. It's unusual at rest. It would not occur at rest for people with normal lungs. Patients with COPD, it usually does not cause hypoxemia at rest. So patients with COPD have hypoxemia at rest. It's due to VQ and other things we'll talk about in subsequent lectures, usually not due to diffusion limitation. However, it can occur, hypoxemia, the diffusion limitation can be a cause of hypoxemia with a low diffusing capacity, COPD, pulmonary fibrosis, in combination with a low inspired oxygen, altitude, flying in an airplane, disease creating a low alveolar PO2, VQ mismatch, and an increase in pulmonary blood flow, such as with exercise, or in a patient with lung disease, if they have an increase in cardiac output secondary to things like sepsis. So sepsis can uncover a diffusion defect in patients with lung disease. So then this is studied in the pulmonary function lab as the DLCO. And all of you as students, maybe not since you were students, have measured DLCO. So DLCO is the ratio of the uptake of carbon monoxide from the lungs divided by the alveolar PCO2. So as you recall, for DLCO, single breath DLCO, you breathe in carbon monoxide, 0.3%, hold your breath for, I think it's 10 seconds, the students may remember more than me, and then you measure the difference between the amount of CO that's breathed in, the amount of CO that's breathed out. That's the CO uptake. You measure the end tidal CO when you breathe out. That's the alveolar CO. So it looks simple here, as you know. It's not quite that simple in the pulmonary function lab. So CO is used because CO is diffusion limited, as I pointed out before. Normal DLCO is about 25 millimeters per minute per millimeter of mercury. CO is reduced by things like emphysema, COPD, pulmonary fibrosis, pulmonary embolism, pneumonectomy, ARDS. DLCO is increased with exercise because there's recruitment and distension of pulmonary capillaries. So next month when we talk about pulmonary blood flow, we'll expand upon that a bit more. And often the DLCO is corrected for anemia and lung volume. Anemia will affect the DLCO, which is measured, because the test depends upon hemoglobin taking up CO to maintain the diffusion gradient across the lung. So if you have less hemoglobin, then the partial pressure of CO in the pulmonary capillary will be higher. So there are corrections for that. And then often the DLCO is corrected for lung volume. So somebody that has a pneumonectomy will have a low DLCO because there's less surface area for diffusion. But if you correct it for lung volume, it'll be normal if the remaining lung is normal. Whereas a patient with COPD will have a low DLCO, but they'll have an increase in lung volume because they're hypervolemia. So often the DLCO will be corrected for lung volume because if someone with a pneumonectomy has a low DLCO, but the ratio of DLCO to lung volume is normal, that would suggest that the remaining lung is fairly normal. Okay, so now let's talk a little bit more about CO. So the discussion of diffusion and diffusing capacity then is a nice segue into talking about the biology of carbon monoxide, which has received a lot of academic interest in the last 10 or 15 years. And it's beginning to have clinical interest as well. And there is now work that's ongoing. In fact, Mass General is part of that work to look at the potential of CO as a therapeutic agent. So as we all know, everyone in this room knows that CO is toxic at low concentrations. So at 1% inhaled CO, it is lethal because of carboxyhemoglobinemia. But the thing that is becoming increasingly appreciated is that CO is produced by normal metabolism. We'll explain how in a few slides. And not only is CO produced as part of normal metabolism, but that has a biologic effect. So our bodies, right now, all of us in this room, are generating CO. So our bodies are CO-producing machines, and that has important physiologic and biologic benefits. So when we talk about CO concentration, we refer to the concentration typically in parts per million, as we do when we talk about inhaled nitric oxide. And just to remind you, there are 10,000 parts per million and a percent. So in the pulmonary function lab for single breath DLCO, typically it's 0.3% of CO which is inhaled, which is 3,000 parts per million, which is a lot, but it's only for 10 seconds. So it would not be a good idea to do the DLCO 10 times in 1 hour, because you would get an appreciable carboxyhemoglobin as a result of that. So carbon monoxide, most of us think about carbon monoxide because of its toxicity, carboxyhemoglobin. And certainly that's an important consideration. Exhaled CO has been used for many years in smoking cessation programs because, as we'll see in a minute, the amount of CO that we exhale is very closely correlated to the carboxyhemoglobin. So if someone is in a smoking cessation program and they say, "You did a good job, I haven't touched a cigarette in 2 weeks," and then you measure their exhaled CO and it's increased, they're probably lying to you. So it's used in CO. It's used in smoking cessation programs. And then CO is used for DLCO. I'm not going to say anything. Well, I may have one additional slide about that, but we've already sort of talked about that. But the biology of this, which is important, is the result of an enzyme in our bodies called heme oxygenase. I'll tell you more about that in a few minutes. And that has led to the recognition that there is an important physiologic role for CO. So if you inhale CO in a fire, and you have a high carboxyhemoglobin, that'll kill you, for sure. However, if you are not normally producing small amounts of CO in your body, that's not healthy either. And then we'll finish up by talking a little bit about the potential for CO as a therapy, which my guess is at least 10 years into the future, but it is now being investigated, as some people like Lloyd and Ernie have helped us with for some subjects up in the middle. So CO toxicity is important. It accounts for hundreds of deaths and thousands of ED visits in the United States every year. However, it's interesting to note that the total deaths from CO poisoning have increased significantly over the last 15 years. And in fact, that's true not only for accidental poisoning, and that may be related to CO detectors in our homes, but also due to intentional deaths that have increased significantly in recent years. As I was putting together this talk, I was surprised when I came across that tidbit. So emergency departments are seeing fewer patients with CO poisoning. Both OSHA and NIOSH have established exposure limits in the workplace. So persons who work in places where there's the potential to be exposed to CO wear little CO detectors. Those of you who have been around up in the MICU when we have dosed patients with CO have seen the little CO detector that we hung on the ventilator to measure the concentration in the room. And then, I guess this maybe is the public service part of the talk, is the importance of home CO2 detectors, CO detectors. So the way that home CO detectors work is the alarm goes off either in response to concentration or time. So you can see that on the slide. So a high concentration of CO takes very little time for the alarm to go off. Lower concentrations take more time. But the sort of the public health part of the presentation this morning is, if you don't have CO detectors in your home, next time you have a day off, go to Home Depot and get some. It really is life-saving and likely accounts for this reduction in accidental deaths related to CO poisoning. Interesting, a paper published about 5 years ago showed that if you survey people, and I'm not sure if it was this study or another study that I saw, when they surveyed healthcare practitioners, physicians, nurses, respiratory therapists, PTs, and so forth, everybody said that they had a smoke detector. Nobody doesn't have a smoke detector in their house. But a lot of people said that they did not have CO detectors. So again, if you don't have them in your house, get them. So Home Depot, Lowe's, Sears, wherever.
They make combination ones now.
Correct, yeah.
Yes.
The ones I have in my
Those.
house are combination ones.
Yeah.
In fact, I have the ones in my house are combination. They're all wired together, so if something goes on in one room, it buzzes in the other rooms of the house. So CO poisoning has to do with the fact that hemoglobin has an affinity of over 200 times greater for CO than for oxygen. So the hemoglobin molecule, given a choice of binding to CO or binding to oxygen, it'll take CO every time. 200 times greater affinity than for oxygen. So the result of that is that carboxyhemoglobin does not carry oxygen. So if you have a 50% carboxyhemoglobin level, half of your hemoglobin is not capable of carrying oxygen. But it's worse than that, because carboxyhemoglobin also causes a left shift of the oxyhemoglobin dissociation curve. So not only is there a lot of hemoglobin that can't carry oxygen, the hemoglobin that is carrying oxygen is not releasing that oxygen to the tissues. So there is not only an anemic hypoxia, but there's also an affinity hypoxia because the hemoglobin holds on to the oxygen more tightly. And beyond that, CO poisoning, CO binds to cytochrome and myoglobin in our bodies, and it releases all kinds of nasty things like myeloperoxidase, proteases, reactive oxygen species. So CO really pretty much wrecks the whole system. And that is beyond just the effect of CO binding onto hemoglobin. So then how could we assess carboxyhemoglobin? Well, the gold standard is to do co-oximetry of blood, either arterial or venous blood. Arterial and venous carboxyhemoglobin levels are very similar. What you may or may not know is that there are now pulse oximeters on the market that will measure carboxyhemoglobin. So they measure oxyhemoglobin, they measure carboxyhemoglobin, they measure methemoglobin, they measure total hemoglobin, but they're not very accurate. So I actually have a paper coming out, a review paper in Respiratory here in December, where I review the studies on the accuracy of the pulse oximeter to measure things other than oxyhemoglobin. And the accuracy is not very good. And in fact, it is very controversial in emergency medicine circles as to whether or not pulse oximeters that measure carboxyhemoglobin should be used in the emergency department and should be used in the field. I don't know if they're used here or not.
I think they get false negatives and then.
So they got them, but they don't believe them, is what you're saying. So.
Yeah, we just get a blood sample.
Yeah, so it's very controversial as to whether they should be used or not, because the problem is you get a false negative, and then that can have bad outcome for the patient. And then the other way you can measure carboxyhemoglobin is measuring exhaled CO, like an end-tidal CO. So you blow into a meter, it measures the CO and the exhaled breath, and it has been shown from many years ago that that closely reflects the carboxyhemoglobin. So here's a study published way back in 1981. I won't ask who was born then, but this was way back in 1981, looking at exhaled carbon monoxide in parts per million and the blood carboxyhemoglobin level. I think this is venous blood. And you can see there is a pretty reasonable relationship between the amount of CO in the exhaled breath and the carboxyhemoglobin level. And one of the places this has been used is in smoking cessation programs. I'll get back to that in a minute. So treatment for carboxyhemoglobin is, of course, 100% oxygen. So with 100% oxygen, the elimination half-life is only about an hour, as compared to breathing air, which is around 4 or 5 hours. And as we have all been taught, use of hyperbaric oxygen clears CO from the bloodstream much more quickly than normobaric, 100% oxygen. And there was this very important paper published back in 2002 where they reported in the New England Journal of Medicine a 46% reduction in cognitive sequelae 6 weeks after HBO therapy as compared to 100% oxygen under normobaric conditions. And in fact, this study drove a lot of clinicians to think more seriously about hyperbaric oxygen for CO poisoning. However, not all other studies have agreed with that. And in fact, a Cochrane review is just the Cochrane organization does lots of systematic reviews and things. And 5 years ago, they published a review suggesting that the existing randomized trials do not establish where HBO reduces the incidence of adverse neurologic sequelae. So this study got a lot of attention when it was first published. Other subsequent studies have not been as conclusive regarding the role for hyperbaric oxygen. That said, I think everybody would agree that in the setting of a high carboxyhemoglobin level, if HBO therapy is available, patients should likely receive it. So this is something now that I've talked about, I've mentioned a couple of times already. This is a paper in Chest looking at using exhaled carbon monoxide as an indicator of whether patients in smoking cessation programs actually quit, as they may say that they did. And in fact, they concluded that measuring breath CO, so blowing into a CO meter, provides an immediate, non-invasive, simple, and effective way of confirming a patient's smoking status. So I know that there are, I don't know how universal this is, but I know that there are smoking cessation programs where this is part of the program, so that they can determine if patients really have quit smoking. So they'll either use exhaled CO measurements, or they measure cotinine in the urine. So now some fun biology. So this is the biology of heme oxygenase. Very important enzyme in the body, the importance of which has only become appreciated over the last 10, 15, maybe 20 years. And this has to do with the metabolism of heme, or of heme and hemoglobin. So when hemoglobin breaks down, it first breaks down into the protein part, which is the globin, and the iron part, which is the heme. The heme is then further metabolized in the presence of this enzyme, heme oxygenase, to produce iron, biliverdin, which then becomes bilirubin, and carbon monoxide. And what has become increasingly recognized is that the CO that is produced as a result of heme oxygenase activity has physiologic activity in the body. Lots of different types of physiologic activity. And in fact, the inducibility of heme oxygenase 1, this one, makes it a very powerful endogenous cytoprotective system. So we think about CO during CO poisoning as wrecking the system, damaging cellular function, but the CO that is produced as a result of this pathway provides important cytoprotection within the body. And now there is beginning to be a lot of interest in whether things might be able to be done in sick patients, like patients with sepsis and ARDS, to bump up the amount of CO in the body, and whether that may result in better patient outcomes. Heme oxygenase is available in two forms. There's one form that's always working as part of the normal turnover of hemoglobin in the body, and then heme oxygenase 1 is the one that can be induced to produce more CO in the setting of disease. So now it has been shown over recent years that CO, whether it's produced endogenously as a result of heme oxygenase, or it's produced, or it's administered exogenously, giving patients CO to breathe in the inspired breath, that affects a lot of different biological mechanisms within the body. So this is probably less important than all of these potentially important biological results, such as CO may be very important as an anti-inflammatory in inflammatory diseases like sepsis. It may have important vasoactive properties. It may have very important other types of very important cytoprotective properties like anti-apoptotic and so forth. So this shows some of the information in the previous slide, yet another way. So CO may result in a lot of different important, useful biological effects within the body, And that may affect a lot of different organ systems, not just the lung, but the liver, intestine, vascular system, heart, kidney, systemic inflammation, and so forth. So then this also points out that if we're thinking about giving CO in the inspired breath, the effect that we're looking for is perhaps not just an effect that is isolated in the lungs, but a systemic effect as well. So that makes inhaled CO different than inhaled NO. So we administer inhaled NO, hoping that the effect will be just within the lungs. When we think about administering inhaled CO, we think about the lung effects, but we also think about the possibility that it could affect other organ systems as well. So there have been now studies that have shown, and this is just a few of them that I put on this slide, that have shown that CO may be an important marker of disease severity. So in this study, they looked at exhaled carbon monoxide concentration in controls like you and me versus patients in the ICU. Patients in the ICU have a higher concentration of exhaled CO. So that may be because of the induction of heme oxygenase activity. Not surprising, in a number of different studies that showed that the exhaled end tidal CO levels were higher in the presence of hemolytic disease. So if there's more hemolysis, there's more heme that needs to get broken down, more CO that is produced. So the heme metabolism then not only causes bilirubinemia, that we already know about, but it increases carboxyhemoglobin and exhaled CO. And then this was an interesting study published less than 10 years ago in critical care medicine where they reported that carboxyhemoglobin is a surrogate indicator of heme oxygenase activity. And they showed that patients who had either a very low level of carboxyhemoglobin, so these are patients in the ICU, mechanically ventilated patients that had either a very low carboxyhemoglobin or a very high carboxyhemoglobin had an increased risk of mortality. So that suggests that there may be a narrow window of therapeutic benefit. Too much is bad, too little is bad, so it's kind of like a Goldilocks effect. And I'll get into that in a minute when I talk about the type of dosing that we're talking about in the ICU. So this suggests that although heme oxygenase is protective, excessive induction may be deleterious. So getting it just right may be the important thing. So over the next slides, what I want to do is to share with you some of the preclinical work that we have done over the last 3 or 4 years related to inhaled carbon monoxide. So as you may suspect, before we started talking about doing CO to patients in the ICU with septic ARDS, we need to show the FDA and IRBs and so forth that we could do this safely in an animal model. And the animal model that we chose were baboons because they are primates. They are the closest thing that can be studied outside of studying humans. And this work was actually done at Duke University in North Carolina. It's very difficult actually to do primate research. And there was a primate lab in Boston, I think was shut down a year or 2 ago. So there's lots of concerns about the protection of animals and so forth. So what we did here was we looked at the effects of inhaled CO administration on acute lung injury in baboons with pneumococcal pneumonia. And essentially what was done was the animals were given experimental pneumonia by injecting the organisms into the lungs of the animal with a bronchoscope, and then they developed pneumonia, and they developed septic effects and so forth. And then we looked at the effect of inhaled CO. We also evaluated a CO delivery system. So one of the big concerns going into this work was whether we could administer CO safely to critically ill patients. Because you've got to be very careful. We don't do it just right. We could be rushing all these patients over to the hyperbaric chamber because they develop carboxyhemoglobin. On the other hand, if we don't give them enough, there may not be a beneficial effect. So I'll show you the delivery system we came up with. we investigated a CO2 dosing strategy to increase the carboxyhemoglobin to 6 to 8%. So based upon a lot of experimental work done in animals, it appears that less than 6% is not going to be biologically beneficial. The problem with going over 8% is then the patient has a carboxyhemoglobin. And patients with ARDS have marginal oxygenation to begin with. You don't want them to have a 20% carboxyhemoglobin. So we had to come up with a dosing strategy so we could hit this target, so that we could show that we could administer a dose that may be helpful but won't be dangerous. So that was a little tricky, and that ties into the CO delivery system. And then investigating the effects of inhaled CO on local, that means within the lungs, and systemic cytoprotection. So is there a hint that there may be benefit from doing this before going on to human studies? So here is the CO delivery system that we ended up working with a company to build. And when you look at it, it looks a lot like an NO delivery system. And it is a lot like an NO delivery system, except that it delivers CO instead of NO. So there is an injector here that fits in the inspiratory limb of the circuit. Here's the injector. So the injector measures the flow coming out of the ventilator, injects CO from a tank of 5,000 parts per million. So there's 5,000 parts per million of CO in the tank. That gets diluted down to 100 or 200 parts per million to be administered to the patient. And then downstream there is a gas sample port, and there's an electrochemical sensor within the device that measures the CO concentration. So there's a whole setup procedure, as there is with NO, to make sure the device is calibrated, working correctly, and so forth. Our biggest fear is that if there's a device failure, then that could have deleterious, that could have catastrophic effects for the patient. So this is just a picture that I took from the lab in Duke where we were working. So here's our CO delivery device. Here it is inline in the ventilator circuit. Here's our PB840 ventilator. And downstream, you can't see it very well, but here is our sample port on the inspiratory limb of the ventilator circuit. Here is the endotracheal tube, which is coming out of the mouth of the baboon who's back here. And one of our big fears was, where's the door if that animal wakes up? They're big animals. So way back in 1975, so as we're digging through the literature, trying to figure this out, we come across this work published way back in 1975. Again, I won't ask who was born then, but I was. I was actually in 1975, already of drinking age, if you can believe it. So in this work, this group of Coburn, Foster, and Kane showed that if we know a number of different variables such as these, and we know the concentration of carbon monoxide that is inhaled, then we can predict the carboxyhemoglobin level over time according to these relationships. So it occurred to us that if we were to administer, say, 200 parts per million of CO and measure their carboxyhemoglobin at 20 minutes, then we could predict what the carboxyhemoglobin level will be at 60 and 90 minutes, so that at 20 minutes we could decide whether or not we're likely to hit the therapeutic dose or to harm, in this case, the animal, or harm people in the human studies. So it turns out, actually, that the relationship worked out very close. So here is the estimated carboxyhemoglobin off of these relationships. Here is the measured carboxyhemoglobin. They were very close. Got us, for the most part, right in that range of 6 to 8% carboxyhemoglobin. And in fact, for the studies, first we used an Excel macro, and then we programmed this into MATLAB, so that at the bedside, some of you who have been around would have done this up in the NICU. We plugged this stuff into the computer to do these estimations. So with this work, we were increasingly confident that we could give CO to people without killing them. I mean, that's really the fear to this day, is that we could accidentally give somebody a very high carboxyhemoglobin level. So then, did it help these animals? So these poor baboons who we gave pneumonia, did they get any benefit from the CO? So you don't have to be a histologist. I'm certainly not. But here is the histology. Here is the control. So this is without disease. This is what the lung looks like with pneumonia. So not very good gas exchange across that lung. And here is what happened in the animals who got inhaled CO with their pneumonia. So is this normal? No, it doesn't look like this, but it certainly looks a whole lot better than this. So it suggests that there may be a local beneficial effect of CO in the lungs. Now I also put on the slide, and I thought about this when I was reviewing this last night, it's not on your handout, but we gave low doses of inhaled CO, 100 to 300 parts per million. So remember in the pulmonary function lab we used 3,000 parts per million for DLCO. So low doses of CO and only administered for 60 to 90 minutes. So this makes it different than how we think about inhaled NO. Right? We put on inhaled NO and we keep it on until Bob says we don't have any more money to pay for it. So with CO you can't do that. Because what would happen if you put CO on and you just kept it running? Well, the patient would develop a lethal carboxyhemoglobin level. So it's only short doses of the drug. So one of the things that will have to be worked out is if this ever becomes clinically available, the delivery system will have to have timeout features so that you start the dose and it shuts off in an hour or something like that, so that if there's a code going on down the room, the patient who's getting CO doesn't get 3 hours of CO by accident.
So how
Now-
does that affect gas exchange in those animals?
There was very little effect. There was no effect. Well, we didn't study it long enough to look at the effect in PO2. That there wasn't a lot of effect on gas exchange as far as PO2 and PCO2 and so forth. What I was going to say is their oxygen delivery decreased a little bit because of the carboxyhemoglobin effect. But the overall oxygen delivery did not change by very much. Now, I'm also thinking we did not come back, so we gave the dose for 60 to 90 minutes. But here, this is actually a couple of days after this or this. So I don't know if we have, we probably, I mean, by this time, I was back in Boston. And I don't think they put in lines and drew blood gases and so forth. But you would think the gas exchange here has got to be better. But I don't think we measured it. We measured it for the short time, but it doesn't have the effect of CO.
It's not that quick, the
Right.
response.
Correct. Yeah, and that's the thing too that will be difficult for people to appreciate at first with inhaled CO. With inhaled NO, when it works, you see the sac go up. Yeah, you're not going to see that here because it's just a different mechanism. So then, as I was helping with this work, I introduced new words into my vocabulary, like mitochondrial biogenesis. That's kind of a cool thing to say. But there was a whole bunch of basic biology work that went along with this study, where they looked at what happened to mitochondria within the cells of the lungs with CO. And the bottom line was that there was an increase in mitochondrial mass. There was mitochondrial biogenesis. And as you know, the mitochondria are the workhorses of your cell. So having more mitochondria is probably a good thing. So it may then be cytoprotective in that regard. And then the other thing that was looked at, and again, I had nothing to do with this work, but they looked at others in the group, looked at the effect of inhaled CO and sepsis-induced renal antioxidant defenses. And the bottom line here was that with the inhaled CO, not only did we see effects like this, and effects like this, which are in the lungs, but there were also beneficial effects in the kidney, suggesting then that inhaled CO may be, it's really premature to say whether it will be or not, but it has the potential can be beneficial systemically as well as just within lungs. So then could we use this to measure DLCO in mechanically ventilated patients? So we're giving CO, and we're measuring the amount of inspired CO and so forth, that we're measuring carboxyhemoglobin. Could we possibly measure DLCO? And in fact, in this work, we did measure DLCO in the baboons. So this might have the potential to allow us to measure DLCO in mechanically ventilated patients with ARDS. And there have been a couple of papers published just within the last 5 years or so that has suggested that there may be a role for measuring DLCO within the lungs as a way of evaluating the potential for recruitment and so forth. So this work has the potential then to be used maybe diagnostically as well as therapeutically in ARDS. So this is all now part of a phase 1 study. To date, there have been 11 subjects that have been enrolled, about half of them at the Brigham, a few of them here, one of them at Duke University. The work is ongoing. As I think I said before, I think it's probably going to be at least 10 years until we know whether this has the potential as a therapeutic agent for ARDS. So with that, thanks for entertaining me for the last hour, and happy respiratory care.
Thank you, Dean.
All right.